going to welcome Dr. Mark Luciano here tonight. And I usually have the speaker introduce themselves a little bit and talk about why they're interested in Chiari and related disorders. So I think I'm going to start with that. And then I know you have some slides that you're going to present as well, I believe, right? So I'll give you the presenter mode as well. But if you want to introduce yourself.
Sure. I'm Mark Luciano. I'm a neurosurgeon. I worked for many years in Cleveland, but for the last 5 years, I've been working here in Baltimore at Johns Hopkins University. Here, I head the CSF disorders group, and CSF disorders includes things you sure may have heard of, hydrocephalus and things like pseudotumor cerebri, and I'll talk about some of these fluid disorders. And I also was very interested for many years in, of course, Chiari malformation. And I really do consider Chiari malformation as one of the disorders of the fluid in the brain as well, and it's very much influenced by the fluid in the brain. Hydrocephalus and other forms of problems affect Chiari, and that's really the point I want to make and illustrate and talk about for the most part in this session. But I'm also, of course, open to other topics. But for many years, we've done Chiari decompressions for me, first in children, and also now a lot in adults. And it's impressed me over time how our thinking about Chiari has, in a sense, changed, or at least my thinking. And a lot of it has to do with all the exposure that I've gotten in fluid disorders in the brain. And we are currently doing a study looking at the pulsation of the brain, how it's deformed in its shape, and how it's affected by the surgical procedures we do. I've also done studies in collaboration with psychologists and scientists in the Cleveland area about the psychology of Chiari, mainly how Chiari might affect, well, personality, emotions, and cognition. And a lot of that is really just starting and becoming very interesting. So I've been interested in research and years of clinical work in children and adults.
Awesome, thank you. That was pretty succinct considering. All right, so I'm going to give you presenter abilities. Let me know if you get that.
I will share.
Perfect.
Then if I can, I'll go into. Okay, can people see these slides?
Yes.
And I don't want to overemphasize these slides. I'll go quickly through them, and they're mainly to show you a few dynamic pictures and to kind of illustrate the journey I was talking about from when I was doing a lot of pediatric cases and considering Chiari malformation a malformation, that is a alteration in the shape of the skull and squeezing of the brain in the back, to thinking of it later on in much more complicated ways. In the context of the fluid dynamics that are in that skull. Just to say, we have a Chiari group here with neurosurgeons treating kids and adults, and I want to say we may touch upon some of the things that work that we've done and ideas that I've shared with a lot of people throughout the country, but I'd like to especially call out to people in Ohio that I mentioned doing research with, engineers, Concord Chiari and Bobby Jones, Chiari and Cerebrospinal Foundation, of course, you're here. And as I mentioned, my current grant is with dynamic motion in Chiari malformation. So this is kind of classic Chiari malformation slide. First of all, it calls it a malformation, implying that there's an abnormality in shape, perhaps in the skull. I used to think of Chiari quite simply as, well, maybe a brain or a cerebellum a little bit too big for that area back in the brain, what's called a posterior fossa, and a squeezing that occurs, and I'm sure everyone online is very familiar with this because you're here, but the squeezing here at the cervical medullary junction between the head and the neck. And here you see that famous measurement of the descent of the tonsils. Here's the bottom of the skull, the great hole, the foramen magnum, and the tonsils going all the way down to here. That's probably about 2 centimeters or so down below. And that's certainly considered a descent of the tonsils when you hear that term. Moreover, you can see that there's not much room here. There's not much room for fluid, and the shape of these areas seem like they're squeezed. Well, this seems to make sense that this is not good, and this may cause symptoms, may cause pressure and pain. It also was believed that compression also blocks up the flow areas and passages in the spinal cord and can cause a syrinx. And I'm being very simplistic in the pathology here, but this is the general thinking, was the blockage up here caused fluid accumulation in the spinal cord. And of course, you have the headache, the neck pains, cranial nerve dysfunctions. Cranial nerves are nerves that come off all around this area that control the face, swallowing, and it can also, of course, affect hearing and balance as well. So these cranial nerves, of course, can be affected because they're squeezed. And then, of course, spinal cord dysfunction. Of course, spinal cord controls the arms and the legs, and you have that fluid going all the way down the spinal cord. So this kind of makes a neat, compact, consistent idea of what Chiari malformation is like. But, you know, a neurosurgeon's simplistic view of anatomy causing the squeezing in the skull, which then causes symptoms, is not always that simple. I wish it was. And of course, the anatomy is affected in different ways by perhaps genetics, and this is being looked at in several centers around the country and world. And also effects of environment. By environment, I mean what happens to the brain and the structures during a person's lifetime that causes the anatomy to get squeezed and symptoms to evolve. So this is a pretty simplistic way of looking at it. And we know it's simplistic because, well, like, look at these two pictures. I picked these pictures because the tonsils come down about the same amount, something like 10 millimeters, about a centimeter or more. But I picked them also because they're different in other ways. They're different in the way the fluid spaces look, bigger or smaller. They're different in the syrinx down below. And also, quite honestly, you can't see this in the picture, but they're different. They're different in symptoms. Only one of the patients is symptomatic at all. And it may not be the patient that you imagine is symptomatic. And so it brings up the question, what are we missing here? When we talk just about the tonsils being down a certain amount, it certainly, we know, can't predict if a person has symptoms, and so must not really necessarily be the fundamental part of what is going on in Chiari and what makes a person symptomatic. And if we don't know that, then we don't really know exactly who we should treat and how we should treat. It was always a sad thing when we do a Chiari decompression and we find the person still has the symptoms. Why did it fail? And it can fail. We all know it can fail. It can make a person actually sometimes get worse with the Chiari symptoms. So there's obviously a lot to know, and it goes beyond tonsillar descent. So what are we missing? Well, you know, obviously cerebellar descent is much too simplistic. You know, so we bring in other things, like I mentioned, compression of the spinal cord, compression of the cerebellum, loss of those fluid spaces. So we still can look at the static sagittal view of the brain that you saw and look at more than just tonsillar descent. We can evaluate some of the fluid spaces that go up and down. And indeed, in one of the projects several years ago, we looked at how can we get the actual volume of the fluid spaces, not just one little measurement, and how can we assess how much resistance there is to fluid flow, and does that make a difference in symptoms? So one thing that I think we miss is all the dynamics that go on in the brain and with the fluid. We're looking at static images, and one thing that's of course come up is we're looking at static images in a horizontal neutral position. And many of you have heard of, you know, sitting upright MRIs, and thinking that maybe things will shift in a way that demonstrates more problems, more compression, or more descent of the tonsils than when a person's laying down. And you know, I have to be honest, I don't think that has shed much light, at least in my practice, finding patients that have revealed Chiari compressions and so forth when they're up versus they're down. But these are the kinds of things we're looking at and want to look at. One reason I think is that the brain has almost the same density, not quite, but almost the same density as the fluid around it. So it kind of doesn't just drop down when you stand up. But in any case, these are kind of the things that we reach out for to look for. Why does this person have symptoms and this person not? Am I missing a Chiari here in this static picture? The effective head position. If something looks open, but then when you move the head flexion or down, somehow closes up those spaces. That's a key concept that has led many people to do flexion extension films, which I think in my practice and in many other people's has in some cases revealed people who are tighter that you would say, well, I don't think that person has much tightness there or much compression to go along with their tonsil descent. So that's something which is, again, reaching out. And it also speaks to not only compression of the brain, but the effect of those fluid spaces around. And I'll keep coming back to fluid spaces because we're going to be talking a little bit about hydrocephalus and fluid problems. Also, you can fail in treating someone's Chiari, even if you do a very nice decompression, if the cause of the symptoms is something else. I mean, that's obvious. And in the past, historically, people have also looked at tethered cord. We know that tethered cord can be associated with Chiari as sometimes, but what we are really uncertain about is how much is it ever really the etiology, the cause of downward tonsils, or how much does it really cause symptoms? And these are really uncertainties. So people are searching for the relationship between tethered cord, which is the spinal cord being pulled down in the spinal canal, held down at the bottom near the sacrum, down below. We can look at identical pictures of compression, and one person has symptoms, the other one doesn't. Is it because there was a bruise or injury or inflammation in one that we're not detecting the others? And there's many people studying CSF, for example, looking for inflammatory markers that might say this person is having a problem, this person's has the inflammation. And again, what I'm focusing on a little bit here is the fluid. Changes in fluid pressure up in the head, or the flow of fluid, or the fluid pressure in the spinal canal. Also, I should mention that every time your heart beats and your brain throbs and grows, it pushes fluid down your spinal canal through that very small junction between your head and your neck, the cervical medullary junction. And that junction, of course, is much smaller when those spaces are blocked up with the tonsils and things are crowded. So every time your heart beats, fluid's going up and down, up and down, up and down. And that dynamic interaction between the head and the spinal cord can be disrupted by a Chiari malformation or Chiari anomaly. This is a early picture that I looked at, and when I look at this picture, I think of how I would deal with questions from the family about. They said, well, will this go away, or why is this here? And I would say, no, this Chiari, as you can see, again, is probably over a centimeter, maybe 1.5 centimeters down. It goes way down here. It's wedge shaped. It's pretty tight. And I would say, no, that's an anomaly that is going to be squeezed, and the brain is squeezing down on it. And the way to solve that is to take away, do, as you all know, a Chiari decompression. Well, in actuality, this one and others that I've seen look just like a malformation, if you will, of the posterior part of your head, which is squeezing down on that cerebellum tight. But what this is an acquired hydrocephalus. This is acquired after someone was being treated for hydrocephalus with a drain in their lumbar spine. It's called the lumbar drain. It was actually a lumbar shunt, and it caused low pressures down below. And with the differential pressure, the tonsils were actually sucked in over time and pulled downward. This is actually reversible. I'll show you some examples. This is actually reversible if you stop that pulling from below. And this is very important because we do it sometimes intentionally, like that shunt I mentioned. But it also happens for various causes, these fluid dynamic changes, unintentionally or in processes of disease. So fluid dynamics can create a Chiari that is really constriction between these bony elements. This is the bony bottom part of the skull. But the problem is really not the bones. It's the CSF dynamics. So what are CSF disorders? Well, many people have heard of hydrocephalus, accumulation of fluid in the head, build up. You make a pint a day. It's made inside the brain, flows outside the brain and around, and then flows down the spinal cord as well, and is absorbed in various places in the spinal cord and brain. If that flow is blocked anywhere, or if the absorption is blocked, the fluid builds up, and those fluid spaces inside the head, called ventricles, swell up and get bigger. That's hydrocephalus in kids and adults. That fluid is circulating around, and there are some narrow passageways called aqueducts and other areas where it can get blocked and trap areas of fluid, create cysts, and create parts of the brain which swell up. There's also types of CSF disorders where the pressure of the fluid is high, but it's not building up in one area, it's just high everywhere. And that's intracranial hypertension. And that's when the veins of the brain are blocked. The pressure in the veins goes up, and then the fluid pressure goes up because the fluid usually gets absorbed into the veins, and it can't with that high pressure. So that's another CSF disorder that we often treat with shunting. Another one important, and based on an earlier slide, I think you can understand, the intracranial hypotension or CSF leak. If you have low pressure in the head, then the brain can sag down, and it can crowd down into the neck area and cause a blockage. And this is one of the main things that we're concerned about when we see Chiari malformation. Is it acquired, is it caused by a differential pressure, either from above or below in fluid pressure? Is there, I had the example of the shunt from down below that obviously caused low pressure, but you can have a leak in your spinal canal, a leak that is really in many other ways undetected and can manifest as the sucking down of those tonsils. And when they do suck down in that way, you can have all the symptoms and the anatomy of a Chiari malformation. So all of these things can be related to Chiari malformation. They can make them worse, and they can be utilized in ways of treating that obstruction at the base of the skull. And so Chiari and cerebellar are indeed, to a great extent, associated with Chiari and CSF disorders. Well, what causes the crowding and the symptoms? And I've mentioned some of these causes. So of course, if the back of the head is small, and there's been studies that show overall there is a statistically smaller posterior fossa, and there's many measurements that have been done posteriorly at various angles and looking at volumes as well to try and define what makes that smaller area back there. If it is small, and it is in many forms of Chiari, then that cerebellum, when it grows up, is just tight in there. And so it's a direct compression issue, all right? Also, as I mentioned, motion of the skull, if the spine, or the spine, I should say, could cause a compression at certain angles. That's more direct compressions. Or, and this gets more to the fluid dynamics, in that the brain can be pushed backwards. Of course, it could be, unfortunately, something like a solid mass or brain tumor, but it also can be pushed back by hydrocephalus or fluid collections and cysts, or by the pulsation of fluid with every heartbeat that I mentioned. And another way for Chiari to be created, in a sense, or the cause of that crowding, is a spinal fluid leak. And I mentioned earlier that there was another consideration of tethered cord. And I put a question mark there because I really wonder if that is an etiology. I do believe that in many cases that spinal fluid leaks or shunting are, if not the etiology of a Chiari, and many times it's not the etiology, can at least influence the Chiari and can exacerbate it and make it worse. And we do have to watch out for them. So crowding in the posterior fossa can be caused by squeezing right there, or pushing down into the neck and causing the tightness, or by, in a sense, sucking down or pulling down. Now, once you have that crowded posterior fossa, and I won't get into this because it's not really part of this fluid dynamics, but we really don't understand exactly what causes the symptoms. Is it just the compression of the brain? The brain feels no pain. Or is it the coverings around the brain, the meninges and the nerves that innervate them, which seems like a good possibility? Is it due to inflammation of those nerves? Or, as some suspect also, that the blockage of that CSF movement, remember I said normally it goes up and down, and it normalizes the pressure between your head and your spinal canal. If that's blocked, does that cause symptoms like headache or other dysfunctions of the brain? Finally, other symptoms, hyperflexion and movement of the head, the association of these other things, syrinx, hydrocephalus, symptom, all these things have their own sets of symptoms that can also overlap and add to the way a person presents with Chiari malformation. So here's a few examples. Hydrocephalus building up. These are the fluid spaces, the ventricles of the brain. And this is, you'll have to take my word for this, about 2-3 times the normal size. This ventricle back here is called the fourth ventricle, and this is probably 3-4 times the normal size. And this all contributes to push this part of the brain, the cerebellum and the tonsils, downward. And here you see a Chiari malformation. Now, if I see this, and the patient, even if the patient has symptoms of Chiari malformation, I could see that there's some blockage of fluid up here. And it would be actually not a good idea to do a decompression here. Why? Because it's not the primary cause of the Chiari, and because if you decompress when there's pressure up here, then there's a possibility that things just push on down farther and recompress farther down, making things, if anything, worse. So one of the lessons here, when you have a hydrocephalus, and this is an obvious one, they're not always this obvious, that you should treat the cause, the dynamic cause, the fluid problem first, and not necessarily do a Chiari decompression in this sort of situation. Here's another kind of situation. This is the spinal cord coming down. You can see the top of the syrinx being the fluid in the spinal cord. You can see the tonsils coming down to well below the foramen magnum. And here, the cerebellum's not big. As a matter of fact, there's a big space, a fluid area. And there's fluid cysts back here, which can play a role in pushing the tonsil down. Again, if you're going to do anything back here, it should include decompressing or draining any CSF collections or fluid collections which are contributing to pushing down. Again, it's not the bone as much as it is the fluid that's pushing that brain down into the junction. This is a child who had very difficult to control hydrocephalus. And when he had a problem with that fluid building up in these ventricles, he would end up in the intensive care unit with a heart that slowed down and acute mental status changes. He would become lethargic and sleepy. Well, many shunts didn't work in him, and someone put in a shunt in the spinal canal. This is a similar case of the adult I showed earlier. And you see here, there's no Chiari malformation. There's no bony problem here. There's no compression whatsoever. But this is the way we saw him, and we were consulted, not only for the hydrocephalus, but they said, oh, there's a Chiari malformation. Well, there was, and you can see here that the area down here is quite tight, and the tonsils are farther down. And it occurs that maybe, hey, the Chiari itself is causing symptoms. We should decompress the Chiari. Again, that's not a good idea. It's not a good idea because this problem is due to a fluid dynamic problem with fluid being drained from below. By the way, I see a fair number of patients that have Chiari and have hydrocephalus. And it's a very tricky business to treat because if you drain too much, if you drain too little and the fluid builds up here, it pushes down this area that's already tight. And these patients can have crises of brain compression and have collapses, have bradycardia, and have all sorts of problems. And they're very sensitive to shunt failures. On the other hand, it's happened quite frequently that a person's had a shunt for years. The shunt looks like it's working just great. As a matter of fact, for years it's been draining too much. And that's causing sagging and the Chiari to be created. And what happened is that you don't need to do a Chiari decompression or redo Chiari decompression. You need to regulate the fluid shunt better. In this case, you can see afterwards, we took out the shunt from down below, and the tonsils didn't come up to this level, but they came up enough that both the symptoms of the Chiari disappeared, and also the hydrocephalus became much easier to regulate. So this is another example of pseudotumor. I won't go in detail, but the theme is the same. We didn't treat the Chiari directly, even though it's here, and they were symptomatic. We actually, in this case, opened up a vein, decreased the pressure of the fluid in the head, and everything relaxed. And there's fluid that developed around the tonsils, and the syrinx that was there also decreased. So treating Chiari and syrinx without really doing a decompression, because we pay attention to the dynamic aspects of the fluid, and in this case, the venous obstruction. When we talk about dynamics, it's always fascinating to see what's really happening in the brain in a person with Chiari. This area is so tight that every time the fluid wants to go down, every time the heart beats and the fluid wants to go down past this junction, instead of it getting down, it pushes the brain down. And you can see this constant pushing downward with every heartbeat. This kind of pulsation downward does not occur in a normal situation. In a normal situation, fluid passes back and forth, but the brain does not push up and down like this. This is a a beautiful MRI done in a kind of advanced technique from Bryn Martin, an engineer. That is also on our project, looking at deformation of the brain with Chiari malformation. We could also look at this in the operating room, and sometimes these tonsils, this is with ultrasound, really do move and hit the spinal cord with every heartbeat. And sometimes you see them, they're not moving much at all, even though they're just as tight. And we're trying to understand about this sort of dynamic. Here's another set where every heartbeat, the tonsils come down and push on the spinal cord. So how does this dynamic that's induced by fluid movement affect Chiari malformation and the symptoms? Well, there's lots of ways CSF dynamics affect the progression and perhaps symptom development of Chiari. I'm not going to go over this diagram except to say CSF disorders affect at various levels. The dynamics, the crowding, CSF leaks, as I mentioned, can also cause a progression of crowding and so forth. And also you can see here other things that many of us talk about with Chiari malformation, from connective tissue disorders, trauma, cervical instability. All these things can play in to the development of symptoms in people with Chiari. The key here is that the dynamic effect over time can create more crowding and create more symptoms in some patients, and a lot of this is CSF disorders. So that's it. I hope that wasn't too long, but not everyone with Chiari, I should stress that not everyone with Chiari malformation, anatomical Chiari malformation, that is that descent of the tonsils, when we define it that simplistically, not everyone needs surgery. Most people who have that kind do not actually need surgery. And that crowding can occur, of course, from genetic changes, and it's anatomical, but also it can evolve with dynamic factors of CSF movement and symptoms. Generally, it's still true that when things are tighter, then the patient is more likely to have symptoms. But it's a general rule, and the relationship is not always very consistent, which means that when you decompress it, your results are not always so consistent. And this is a part we won't get into, but even when you have a crowded fossa, what determines actually how much pain and symptoms you're going to have, and what those symptoms will be. One of the studies that we're looking into is when you have crowding in the cervical medullary junction, how does it affect higher regions of the brain? How does it affect things like emotional control and attention and so forth? And again, these things are just starting to be recognized, never mind understood. So with that, I'm going to just give this back. If I can find a way to anti-share, stop sharing. I stopped shared, and I just wanted to give you kind of that dynamic view and the view that CSF affects Chiari, and then just kind of open up to any kinds of questions that you want.
Perfect. Thank you. Awesome. That was a really good overview, and it actually touches on a couple of the questions that we had gotten in already. So I'm going to try and whittle them down to some of the questions that maybe need a little bit more explanation or weren't touched on. So you kind of describe what cerebellar ectopia or tonsillar descent is, but what imaging is really required to diagnose or show that for someone going into the clinic?
Well, let's start with the sort of traditional view of the tonsils. I showed many examples of kind of in the midline, that mid-sagittal. We also look at cross sections, and we look at every angle really to describe of a standard MRI. We often, when we get an MRI, when we get a Chiari image, we get a high definition because it shows much better not only the shape of the tonsils and what is seen at the junction, but it can also sometimes show membranes. And sometimes it's as much other blockages of fluid, which can cause symptoms as well. So we get a high definition. We also get what's called a cine flow. That shows, and I didn't show that here, I guess that would be typical to show with every heartbeat, the fluid going up and down. And that is arguably, that gives some additional evidence that there's a fluid space of communication there. This is the kind of thing that we want to see to have normal physiological function. So our standard Chiari test is that it's also the entire spinal cord, because even though syrinxes can be most often in the cervical region, whenever we do a Chiari evaluation, we do it all the way down the spinal cord. So I touched upon other things like flexion, extension. In these situations, in the situations where a person has what looks in all ways as a Chiari type symptomatology, But you look at it and say, yeah, the tonsils are a little down, but it's not really that tight. Is it really causing the problem? Then it is very, very probably thorough to do a flexion extension to see if in certain anatomies we get a true compression. There are also people that make many measurements of flexion extension and the change of the angles because of this idea of hyperflexibility. I think the tie-in of the hyperflexibility and flexion extension films is that if you have a crowding back here, you can imagine that any ability of the neck to flex more, hyperreflexibility, can make it more vulnerable to compression if you're already tight there. So you've got less elbow room, and you're bending more. So flexion extensions I've occasionally done. I don't do it routinely in the first evaluation. And finally, I mentioned the vertical ones. We don't use those routinely at all. The most useful measure has been for me, well, the single, I'd say the sagittal and the coronal views of the tonsils to get an idea not only of the tonsil descent, but the compression of the whole area.
Mm-hmm. So you kind of touch on it when you talk about flexion and extension, but about how often is tonsillar descent accompanied by other problems like craniocervical instability or tethered cord or CSF leak? Is that, how common is it?
Yeah.
To find?
So I would say that the majority of time, Chiari is not associated with an instability. The majority of time, and I'm not going to give an exact number here because I don't think we really know. The majority of time, it's not associated with any tethered cord or hyperflexibility. These other factors, I think, increase your risk of having symptoms from Chiari. But you can have the compression for all those reasons I mentioned, either an anatomically small posterior fossa, fluid issues and pressure changes, and not have either a tethered cord or hyperflexibility. So I think that these things can be considered higher in frequency. Why are they higher in frequency? Because they increase your risk of having symptoms from here. Okay, so if you can have tonsillar herniation and not have much in the way of symptoms, but if you add hyperflexibility, if you add some of these other elements, you may have more symptoms and therefore may be discovered more, and the rate of the association is up. That's very simplistic. There's people that are looking at the genetics to see if there's any genetic ties, and very likely there are. There's certainly ties between abnormal shaped posterior skulls and necks and to constriction or crowding there. So there are associations genetically between tethered cords and spinal anomalies and posterior fossa anomalies. There's spina bifida, which of course is a disease of the whole spinal cord and the lower spine with the tethered cord and Chiari malformation. So there are of course associations, but I would say that in general, those never really, I think, take the majority. Any one of them takes the majority of time, percentage, I should say.
Great. So kind of getting to that though, what are the symptoms that something like this are going to cause? And can those symptoms be positional? So like, would they maybe get worse or better if you're lying down?
So, I mean, classically, we talk about headache and neck pain, and with Valsalva. Valsalva is when you bear down or when you cough, or sometimes when people laugh, they get a more severe headache. The idea is that anything that increases high pressure up here can push those tonsils, which are already tight, push them down even more. We've done intracranial pressure monitoring in patients who I'm concerned about, do they have a Chiari that needs a decompression, or do they have low pressures that are pulling the tonsils down? So we will get an ICP monitoring. It's a pressure monitor that goes in the head. We have them walk around, sleep, and so forth. And we make sure that they don't have high pressure that might be pushing the Chiari down, or low pressure that are sucking it down. But my point about the symptoms is if they bend over or cough, we see high pressure spikes in the head. And those high pressure spikes are sometimes associated with those severe pains that people have with the Chiari malformation. And that's kind of why those are characteristic, because those things you do to increase the pressure in your head push back there specifically and give you and cause the symptoms. So that's one of the things that's very typical. The thing about Chiari is it's in a very busy area, and it can affect, it can affect swallowing and cranial nerves. It can affect the voice. It can affect, even though the cranial nerve that affects the hearing and balance and so forth is a bit higher up, it can affect those things too. It can also cause compression of the spinal cord and the syrinx. So then now you have arm tingling and numbnesses. That can be very common as well. So when you say, how does a Chiari present? That's a whole other big thing, because it's a very busy area. In 80% of people, it's headaches and headache and neck pain. It can be all over the head, but mostly in the back, and often influenced by those things that increase pressure.
So you mentioned about voice. There was a really interesting question that came in before we joined, asking if it's possible that vocal tremors could be linked to Chiari or syringomyelia, which I thought was an interesting question.
Tremors in most all muscles, including laryngeal muscles that control swallowing and the voice. If you have weaknesses in your muscles or problems with the innervation, you can develop tremors. And so you can have abnormalities of the movement of the vocal cords and weaknesses. Sometimes weaknesses, like in children with cerebral palsy, result in actually spasms of the muscles. And so you can have weaknesses and you can have spasms of muscles as well, due to anything that affects the posterior fossa and the upper part of the brain. So I guess the answer is yes. Is it a typical thing? No. Right. There used to be a list on the internet of symptoms you can have with a Chiari malformation. I think there were about 147. And any one of us writing it out could probably check off at least 5 or 6. Some people could check off 15 in their life. And it's because this is such a busy area. And so can I think of a rationale why you might have spasms of the vocal cords or dysfunctional vocal cords? Sure, because the systems that control the vocal cords do function through the posterior part of the brain.
Right. Yeah, I think that's what makes this all so frustrating, is that it could be pretty much anything that's affected by that brainstem area. There's a really interesting question that came in the chat. Do you have any information on Chiari malformation and maybe post-concussive syndrome, and if those are causative in either direction?
Yeah, that is, that I think is interesting. And what we have seen, although I have to say, I don't know that's been ever really demonstrated in the literature, but we have felt that some, like football players, people who have had concussions and who have prolonged recovery from them, some of them are quite tight. When you have a concussion, your whole brain can swell a little bit. The pressure can go up transiently or even longer term, and there can be a tightness. If you already have some tightness back there, you can imagine, and like all the other things I've been talking about, it can exacerbate it and cause the Chiari to be present. So I think that certainly head injury and concussion can be related to the making of a Chiari worse, and also in a way the syndrome of the concussion longer. But I think the head injury can cause a problem not only by generalized swelling and pressure in that area, but we don't know what an injury does to the head on the actual cervical-medullary junction and this cerebellar tonsil and the spinal cord, to maybe cause some bruising and injury, maybe cause some inflammation, which also makes the symptoms worse. So I think the combination of being already tight back there and being vulnerable to concussions and having more symptoms, I think that's real, although I have to say, I don't know of the quantitation that's been done in the literature.
Right. There are really good questions coming in. I'm going to start with this one because we were talking about it a little bit with the connective tissues. How much is brain prolapse or hernia caused by weak fascia, where the connective tissues holding the brain in place maybe just can't do their job properly?
Most of the fascia, like the dura itself, is supported by tissue behind it, fat and other things, and bones right behind it. I would say fascia and so forth in the skull makes almost no difference because you've got the skull right there. All right. In other areas, you have areas of like the lamina and the bones of the spine bridged by soft tissue, the dura, the coverings of the brain, and then fatty tissue and so forth. So there are situations in connective tissue disorders where that soft tissue, the dura, is not supported directly by the skull. You can have outpouchings, right? Ectopias. And these things can look like just sacs of CSF fluid, and people with Marfan syndrome and other connective tissue disorders often have multiple ectasias. And those can be a source of fluid leak. And I think that's usually the way they present to us, because as they get stretched and ballooned out, they get thinner, and then they do cause CSF leaks. I'd say that one of the ways connective tissue disorders may relate to Chiari is by more motion and flexibility in the cervical medullary, as many people have put forward. I think another way is that it makes the fluid pressure in the spinal canal much looser, and even can cause leaks, and that can allow the tonsils more ability to go down, like you saw in those patients that had the low pressure. So connective tissue disorders do allow outpouchings, and moreover, they can allow, because of those outpouching, leaks, and I think that those cause the problems too.
Mm-hmm. So before we get away from the symptoms and stuff, you mentioned cognition and different studies that are being done there, and 2 questions came in prior. So are you aware of any studies being conducted or new studies being planned even in the surgical or the neuropsychological community that might measure Chiari's impact on patients' cognitive functioning over time? So I guess over the lifespan, obviously that's going to take a while to get, but is there anything being done in that area? And as a follow-up, is there anything that's studying associations maybe with like ADHD or executive functioning, autism, different things, and how that might be impacted on the cerebellum?
Oh my gosh, those are two great big questions. Okay, so I'll go to the things like attention deficit and afterwards. The first one was, what was the first one?
So basically, what studies are being done in cognitive functioning?
Well, there is a group, and there's actually a group in Ohio that has studied different ages and longitudinal, but they're doing it in a cross-sectional way in patients who have had Chiari develop at different ages and followed them at different periods in time. And it's a very difficult study because you're looking at very different people with different Chiari malformations, decompressed to different extents. But they're one of the only groups I saw that looked at younger, older patients and looked at deficits and disorders. So I have to say that there's not much known about how it evolves in any particular population as they grow, for the reasons kind of you said. That's a long-term study. That's more than a 5-year grant. That's like a 50-year grant. So we don't know that much because all there's been is a few cross-sectional studies of people at different ages, and they're very different. I think that the question really asks the question, does Chiari malformation affect the entire brain over a long period of time? And I think that's a fascinating question. It kind of leads to the second part of the question. Is I used to think of Chiari affecting back here, and it does. But all those fibers, of course, are projecting up to the thalamus, the centers of the brain, and then to the cortex. In other words, it's communication up and down. So we have to ask the question, if you're squeezing something down here, how does it affect fibers going up and down? And what sort of circuits might it involve? We've learned a lot about the brain in general. We used to think the back of the brain and the cerebellum controlled movements and coordinated your golf swing. No reference to golf here, but it does so much more than that. We now know that it coordinates and probably coordinates even verbal kinds of coordinations, and it also may help us control our not only our movements but subtleties of our emotions and feelings. These are all kind of new concepts for the cerebellum, but it really is real. We can't classify the cerebellum back here as just affecting our movement. It affects so many of these other things. One interesting aspect of this is the middle part of the cerebellum on the bottom has areas that are part of what's called the default network. So what's the default network? If you do a functional MRI, so if we do an MRI, there's a type of MRI which can explore parts of your brain that are active because it looks at when more blood goes to them and more oxygenated blood. So it looks for the patterns of where your brain is active. And once it can define what parts of your brain are active, it then, through lots of computer analysis, can decide which parts of the brain come active together and which ones form, like this whole group of different areas of the brain are networked together and work together. Well, these are called networks, and there's parts of your brain, of course, that activate when you read something or when you are afraid of something or when you're playing golf. And so there's different areas of the brain which are activated, but there's also, and this I think is fascinating because of the cerebellum and Chiari, there's parts of the brain which are specifically activated when you're not doing anything. And it's called the default network. Or it's like, if you're driving your car, steering and accelerating, that's lots of parts of your car are being used. Then you go to a red light and you're idling, okay? And nothing's going on. You're not steering, you're not braking anything, you're not changing anything. You're listening to music, but the car is just purring very softly. So this asks the question, what parts of your brain are active when you're idling? Well, it turns out that some of those areas are back here in the cerebellum. And it turns out that many disorders that the psychologists and the psychiatrists look at, including emotional control, attention control, are related to your ability to idle and then to activate. And so if you have a system which is affecting your idle system and your ability to pull back and then attend to something, then it can have a lot of effects. And it's been looked at, this network, with attention deficit disorder and with OCDs, kind of different poles of the system. And it's also been looked at for emotional control. Now, I have to say that this is all quite speculative. What's not speculative is we now know the cerebellum does a lot more. And what exactly how this default network really works and engages and how it gets disturbed in Chiari is not known clearly. But we at least know now that there are mechanisms, even in the cerebellum, which can affect in very kind of interesting and subtle ways the functioning, even emotional functioning of the entire brain. And I don't want to overplay that because we don't know much about it, but that is a important aspect of what people are also looking into now. And they're looking at the deficits in attention in people with Chiari of all different ages.
Right. Yeah, that's really interesting, actually. I didn't know about that. So I'm trying to think of how to say this. So what are some common issues that, actually, a question just came up in the chat and it's related to this, so I'll do that first. Is there a study happening as far as deficits in attention? I know you kind of alluded to that. Where are those studies being done?
Well, actually, there are a number, and I'd be remiss if I missed some that in other locations. But there are some studies that are being done at University of Akron and at Concord Chiari that they are looking at attention deficits. They're using, and I was a part of some of these studies where we're using electrophysiological measurements, EEG, and also just neuropsych batteries, and looking at attention deficits. So yes, there are studies being done. And actually, we're expanding them.
Yeah, another really good one. So you talk about the cerebellum having issues with like the idling system. Might this explain some problems with insomnia or getting to sleep? Maybe?
Well, it could. When you think about this whole system, it could affect almost everything. So I can't say no, but I can't say that I don't know of any studies that specifically looked at sleep dysfunction with idling. Doesn't mean they're not out there. The default network is not my major area. I'm just a surgeon. I'm just a guy with a scalpel. But but certainly, if it affects these areas of idling and activation, it'd be a plausible area of research.
Yeah. So just before we step away from symptoms specifically, because I know there are a lot of questions in the chat about surgeries and their failures. But first, I just wanted to ask, so you mentioned that every time the heart beats, there's some pulsations. So can those pulsations cause like long-term damage to the brainstem, or to the point where maybe a surgery wouldn't, and I guess it gets to the point of surgical failure, would those symptoms necessarily get better? Or maybe if there's damage, what would you say?
So this really gets to the heart of one of the reasons that people are studying it. Is some may just say, oh, we're talking about a few millimeters back and forth, and we're talking about the spinal cord just moving a little bit. It's probably nothing, except it happens, 60 times per minute, and it happens millions of times in your life. And could it develop some gliosis or problems in itself? The second reason people are looking at this constant back and forth is because its effects perhaps on the elasticity of the brain and the ability. If you push something that's plastic and keep pushing it, over time you'll get farther. In other words, if you keep doing this constantly, will those tonsils go down further? So is it involved in the progression? And that's not certain. And are these changes in elasticity and deformability permanent, or are they temporary? I'd have to clearly say we don't know, because we're just looking at them. But certainly it's possible that these are just functional problems with fluid pressure, that once you open up the fluid space and once the tonsils stop doing all that the progression stops, and maybe some symptoms stop. We know that the symptoms can occur in the brain with changes in pressure with your heartbeat. I mean, aside from Chiari. So it's certainly plausible that some of these symptoms are not due to damage that's irreversible here, but due to the actual pressure changes and the fluctuations themselves. And that would be great, because Chiari decompression, which opens up those CSF spaces, has the potential to equalize the pressure and get rid of that kind of motion and fluctuation. And so it might play a role directly in the symptom relief.
Mm-hmm. So to kind of get to, we have a couple of miscellaneous questions, but I want to get to surgery since that's kind of like bread and butter. What are the options, I guess surgical and non-surgical though, that might help improve CSF flow, or at least symptoms? So I know one thing that happens often is you don't necessarily see more space, but the patient gets better. But what are those options, surgically or non-surgically, for patients?
Yes. So it would be a very interesting question to know if there were, and there are manipulations which affect the amount of pulsatility. As a matter of fact, people often ask, why is it when I run and you get your cardiac output out, so forth, why do I have more symptoms? In a lot of situations where the pressure, things are tight in the head. And so control of pulsatility, not going running, or medications that do that, or control the heart, can affect symptoms from this area in Chiari. It's probably not a very effective way, and it's probably not something you want to do generally, but certainly those things can have an effect, pro and con, as can, again, running and those sorts of things. There is, as I mentioned, changes that we make not of the bony area here at all. There's a lot of things that we do that are, and some of them aren't surgical. For example, one patient we had, they got a stent. Well, it's a procedure. They opened up the vein here, relieved the pressure in the head, and actually, I don't know if you probably didn't see it in that picture, but the fluids, the Chiari was filling up the whole space in the junction. And after that stent was put in, it went up just to show a little sliver of fluid, a tiny sliver. And that was enough to cause a treatment, not only of the Chiari symptoms, but to reduce the syrinx. So sometimes it takes almost perceptibly little difference in what you may see in the tonsil descent or the fluid spaces, but there may be fluid spaces on the side or in the front which open up enough to transmit enough pressure. And so manipulations far away from that junction, which affect the fluid pressures, can affect it. For example, we have situations where a person comes to us consulting, they had a Chiari decompression. Oh, this was and she wanted to know if she can get pregnant. She still has headaches when she's up and so forth. Well, I looked at we redid an MRI. She had the Chiari decompression years ago. And oh my God, her cerebellum was so sunken down. I came and saying, you know, I'm surprised you're just asking about, you know, about your activities. And she confessed that her Chiari decompression never really helped her much, and things have gotten maybe a little bit even worse over time. And I'm looking, of course, how things have sunken down. Well, she didn't need a redo Chiari at all. She didn't need a recompression because it would have just made things sink down. What we did is find a leak in her back, and with a needle, I didn't do this. This is the interventional radiologist. With a needle, put in a patch which sealed a hole where there was a leak in CSF, and that caused enough pressure on the bottom to raise things up enough and alleviate her symptoms.
Wow.
And so, yeah, I mean, it's a procedure, but it's not surgery. And again, it's treating the dynamics of the situation and not just the bony decompression. I will say that my respect for the flexibility of the brain and the up and down motion of the brain, both just the oscillations, but also just generally, has grown so much over the years. I can tell you I've done a bony decompression, and boy, that looks great. And there's space, and I'm really happy with it. But if there's a leak or something down below, and that's happened, all of a sudden it looks like you weren't even there. All of a sudden things are crowded again. The tonsils are even swollen a little bit, and they fill up the whole space. You say, well, if this was such a matter of the bony decompression here, why is it that a fluid dynamic thing makes it look like you almost weren't even there, and you need to do a redo now? And it tells us that, of course, the compression there is a real thing, and tightness there is a real thing that causes symptoms. But the bone itself, the skull itself, is not always the culprit. It's not a deformation of the bone. It's the dynamic and movement of the brain, which is the culprit, and which you always have to keep in mind before you do a Chiari decompression as well.
Yeah. So I guess we'll get into like some failure questions. I guess unsuccessful decompressions, we'll call them, because it kind of touches on that. So there's a question: if a patient has a Chiari decompression and it's considered unsuccessful, when would a second decompression be considered? So I guess sort of to that, how do you test for something like a CSF leak? How do you know it's going to even be there? How do you know it's that versus another decompression?
Well, if we start before the decompression was ever done, any person that comes in, you're asking the question: is this Chiari one that is probably only due to this bony malformation or tightness or small posterior fossa? Some people measure the posterior fossa and say, yours is very small, and I think yours needs to be enlarged. There's sometimes I look at a Chiari and I see that the back looks actually quite normal and large. So it isn't necessarily that. And we look for other signs on imaging or of symptoms that might indicate that it's this fluid dynamic problem. Is there a hydrocephalus like I showed, but also, is there brain sagging? Is there a large amount of fluid above the skull? Means the brain's sagging a little bit. That could be the lower pressure, okay? Ironically, the pituitary gland swells up and gets bigger. And certain veins get bigger. In other words, when you pull fluid out of the brain, more venous blood and pituitary blood engorges. The meninges get thicker. So if I see a patient with thickened coverings of the brain that enhance, big pituitary, a little bit of sag in the brain, these are all subtle signs, especially when you put them together, that this person doesn't have a Chiari problem. They have a problem with low pressure. And you look for those same sort of signs in a person who's had a Chiari decompression. Does it look like, especially if you can get films right after they did it, does it look okay when they did it, but over time it just sagged down into that place? That's that cerebellar ptosis. And that cerebellar ptosis is likely due most of these fluid dynamic forces that we're talking about. The cerebellum gets basically pulled down, not because it's a rock in a pond. It's not really that much heavier than the water, but because of the pressure differential that's developed by low pressure here or high pressure above. So you look for things that indicate that there's generally low pressure. Symptomatology also can point in that direction. A strong aspect of positional headaches. You get up and you have a problem. You lay down, you feel better. That's a general sign of low pressure. And again, markings on the MRI. And if it comes down to it, in several cases where I'm not sure, there's a few suspicions, I put that ICP monitor in the head, like I discussed before, and I look for high or low pressures. If the pressure is entirely normal and not involved, then I think it's back here and I do Chiari.
Okay. There's a couple of people interested in this question. So there's discussion about a report that up to a third of Chiari decompressions eventually fail because of a co-occurring connective tissue disorder, either being missed or ignored, and then subsequent craniocervical instability starts to develop because of some additional mobility caused by removing some of that bone there when you do the Chiari decompression. Is there anything that you can speak to about that? How is it up to a third, or
well, no, I can't really speak to the proportion. I'd have to look at their data. You know what I mean?
Yeah.
And not having the paper and the data before me, that seems like a bit high number, but I'm not going to dispute it because I don't see their data. As I said, I don't think it's the majority of time that there's connective tissue disorders primarily involved. It does speak to the issue of how much we do destabilize when we do an operation back there. And ideally, we're not involving the joints, but even when you involve the muscles back there, you are of course disturbing the structure and the stability to some extent. I, to my knowledge, have not had, when you do purposely limited Chiari decompressions that don't affect the joints and so forth, the instance of a major instability or one that requires fusion that you cause, I think is actually quite low, much lower than 30%. But I agree with the proposition that increased flexibility can be part of failure, for sure. And if a person has increased flexibility, I think they're more vulnerable to compressions and abnormalities here, and your simple de-roofing and decompression may not be enough. So I think that's one of the reasons, that Chiaris may fail. One of the earlier reasons people talked about again was the tethered cord. Maybe they have a tethered cord, and there was an era where people were getting tethered cord releases. And I don't think that really is supported by research, experimental or really clinically. So people have gone a lot of directions. There was a period of time where they said a little decompression is enough. You have small posterior fossa, you have to take off the whole back end and put a new one on that's bigger. That's a pretty big operation, and there's logic behind it. And it all arose because of failure of the basic decompression to work. Well, it doesn't work because we didn't do enough, or it doesn't work because the cord's being pulled down, or it doesn't work because there's still too much flexibility. And I think that flexibility adds something, but I'm not sure how often it really it causes the real failure.
Right. Is there any way to know, I guess, before, assuming this patient had never had surgery before, is there any way to know that that person might be more prone to some instability before you go in, or is that like genetic testing? How do they do that?
Well, yeah, there is both genetic testing and of course basic flexibility tests that most all of us do. And I have to say, everyone says, look, I do this, I have a tissue disorder, connective tissue disorder. Then I usually say that, well, I could do this too. And there's of course a rating scale, and there's the idea that many people have more flexibility than others, and some might get to a range which is problematic. It's probably not a coincidence that a lot of people who have the flexibility are the ones that are the gymnasts and so forth. Maybe they had a propensity for that in the first place. But I think assessing a person's by history and also by the flexibility test, which I won't get into and demonstrate all the tests that you do for flexibility, but they can help you do that. I'm not sure if they would ever change unless you saw kinds of really abnormal angles that might cause abnormal angles of the spinal cord itself, or that you see as causing or adding to a compression. I'm not sure that having a connective tissue disorder would stop a person from getting a Chiari operation if they felt that there was a primary compression there in the first place.
Mm-hmm. And if after that initial decompression, what would be the symptoms specifically to indicate that maybe that patient has like an issue with too much mobility at the back of the head there.
Well, I mean, one of the things that we do is we have them move their head and see if that makes it more symptomatic. Another key test that we've used several times, I think other people may use it more, is to have people in collars and immobilize their head for a period of time and see if that reduces symptoms. So it's in a sense a trial and error. It's an empiric test to see if motion has that kind of effect. Of course, there are angles and things that are measured to see if they're hyperreflexic as well. And there's some dispute as to how much is abnormal. Some people are strict about the angles and some are not. But the point is, if they are having wide variations with flexion extension, and especially if it affects their symptoms, then it's certainly legitimate to consider aspects of fusion. You know, I've had several patients I put in collars for periods of time to see if any motion effects are involved with their symptoms.
Yeah, that's a good differential way to do that. There's a really interesting question, and it's kind of long, so I'm going to just get into it. So someone's son had hydrocephalus, and an original shunt was placed 30 years ago with no revisions. Then they wound up, for some reason, having 4 decompressions. And then after the 4th one, it was for syringobulbia to improve a severe sleep apnea. I don't know what AHI stands for, but AHI numbers decreased to below 5 for 8 days after surgery. But the numbers have increased again, ranging from like 15 to 20. Have you ever had any patients presenting with similar issues? And I guess in May of 2019, they were decompressed, but surgery wasn't able to be completed due to tethering of the brainstem actually on a vertebral artery. So that's a lot, but I'll let you speak to it.
So it certainly is a scary thing when the syrinx from the spinal cord heads up towards the brain stem itself and into the brain. Actually, I have a patient in-house right now with that kind of problem, and a beautiful decompression already. And so you wonder why. And they have a syrinx, obviously, but it's gone up. And I again think in this situation, it is often a matter of flow at the cervical major junction. This person has sagging downward and has a blockage of the outflow of the fourth, which can push fluid down into the syrinx and push fluid up into the medulla. I hadn't thought of it originally, but this person also, and there are a few people, this is like an archetype because I've had a few of these, that, oh, maybe we should do another Chiari decompression because I did it and it thought it was good, but now I look at it, it still looks tight. And so you do another one. And you can see it's the same pattern I was talking about. You're doing the Chiari, you're getting rid of the bony compression, but yet the brain is still sagging and falling. It's a hydrodynamic problem. It turns out that currently, and also patients from the past, they've had shunts for 30 years. Those shunts are very likely not running properly. And one time I remembered an old pediatric adage that if a person has a shunt, no matter what's going on, you think it's scary, check the shunt. And I didn't know what to do with this patient because it was going to be a second redo that came in as a consult. And I could say, yeah, things look a little tight there. But then I remembered, check the shunt. This patient had a shunt since they were age 1. Now, I didn't think the patient had a shunt problem at all because the ventricles were small. So there's probably not a problem. But I did an ICP measurement, and sure enough, there was no high pressure. The shunt was working. However, it was working so much that when they stood up, the pressure went down to -15. This person had chronic overdrainage. And no one suspected the shunt because the ventricles looked okay. They were not getting enlarged. There was no shunt dysfunction. But in fact, those old valves over time can just not drain enough, not be regulated enough and drain too much. And in her, we put a regulatory device which stopped the overdrainage, and gradually over time, her symptoms got better. They never actually completely resolved. They got a lot better, much better than if we did another Chiari decompression. So you have to look at the root cause of compression back here, which can sometimes be, again, even a shunt from above that was put in 30 years ago.
Yeah. Wow, that's terrifying. But good to know that at least that's a good place to start if that's your anatomy.
If a person has it shut for a long period of time, you always have to look at it. If it's failing, it could be pushing, and if it's succeeding too much, draining too much, it could be causing a problem as well.
Yeah, that's a really good point. I had a question that came in, and we're going to get kind of into miscellaneous now, but what is the terminology? Obviously, it just continues to be a problem in Chiari and CSF disorders. So what's the correct name for pooling of CSF in the brain accompanied by an empty sella? So this person suggests, is it idiopathic intracranial hypertension, hydrocephalus, pseudotumor cerebri, or something else?
Okay, so the pituitary is an amazing thing because it's really kind of, it's not really in the brain, it's like right next to the brain, and it's highly vascular. And it becomes, it's like a sponge. If the pressure in the head's low, it expands. Remember I mentioned that's one of the signs of low pressure. And if the pressure is high in the brain, it shrinks down like a sponge you're squeezing, okay? So if you have a partially empty, this is another thing which is not an anatomical thing as much as a dynamic thing. If you have an empty sella, it usually means that you have had or have higher pressures in the head, which have squeezed down over time the pituitary gland. So the partially empty sella is because the sella holds the pituitary gland, and the pituitary gland is shrunk down to the bottom because the pressure above in the brain has done that to it, okay? It's a sign that there has been, it's like the footprint of high pressure. That high pressure can be a hydrocephalus, or it can be a pseudotumor. Very frequently, it's considered a sign of pseudotumor. Why it's considered a sign of pseudotumor? Because in pseudotumor, everything else looks normal, but you have that little telltale smashing of the pituitary gland. In hydrocephalus, everything looks abnormal, so you don't need any other hints. So people often say, look at that, normal brain, but with an empty sella. That must be pseudotumor or intracranial hypertension. What's kind of neat about that is, it doesn't always re-expand completely, but you can get little changes in size, and people look into, can we use that as a barometer? Because it goes up and down, but it's not good enough.
Yeah. Okay, so another question. This is getting away from surgery necessarily, but this patient reports like some nerve pain. And this is really more learning about what's being done. So are there any studies that are being done or medications and trials for nerve pain that you might feel hopeful about? They say, please feel free to stress that I'm not asking for medication recommendations. I stopped taking them decades ago, but this patient is hopeful that maybe one day there will be something for nerve pain. And I actually don't know the answer to this, and I'm actually really interested to see if you have any.
We have a lot of people for various reasons, most of them, quite frankly, outside of Chiari, that have various forms of nerve pain. There's one medication which is the staple that everybody uses, and other things are quite experimental in terms of various forms of anti-inflammatory and so forth. The one that everyone uses is Neurontin gabapentin, and it's fairly successful, and some people don't tolerate it very well. And part of the problem is nerve pain can be a cycle of pain that involves not just the nerve, but centers of pain, that the irregular circuitry or irregular input from the nerve causes abnormalities in even deeper areas. So you can solve it on the outside, but you end up with central pain as well. And so sometimes just treating the quote nerve pain isn't enough anymore with chronic pain. Pain is a very complicated area, and things that which reduce inflammation, gabapentin, which slows down conduction of electrical activity and so forth, can be used and is somewhat successful. I don't offhand know of anything, certainly nothing specific for Chiari, and I would have to say that there probably are lots of people that are trying other things that are more effective than gabapentin, but there's nothing really that's on the market right now that is used as much as gabapentin or Neurontin.
I don't know if you can speak to this necessarily, but complex regional pain syndrome and stuff like that, where basically pain just starts to get like kind of sent into overdrive, and it's almost like a baseline. What's being done? Is there anything that can be done surgically for something like that, or is it again just something that you're prescribing things like gabapentin and hoping that they work?
As far as I know, so far it's just that, but those are areas that are, I think at really experimental level, and I wouldn't know enough about ways of treating that at this point to comment.
Okay. So there's a question in the chat, and I've been trying to look it up while we were talking, but I can't find it. There's a recent report from Dr. Raymond Damadian about the craniocervical junction and how it might lead to varying levels of like brain dysfunction. And I'm going to admit that I haven't read it, so I can't elaborate any more on that. But I don't know if you have if you've read the report or any of his papers, or if you have anything to say about.
So are you talking about how the compression here can affect various areas of the brain?
Right. If you can maybe describe that, and I guess.
Well, I think that's a very, very interesting topic, and because again, the entire bottom of the brainstem and spinal cord can be compressed or compromised. People have done what's called DTI or fiber tract studies to see what areas of the brain are projected to, and it turns out that areas of the brain in the major relay nuclei, the thalamus, that go out to the cortex, and also areas that are affected in what's classically called the emotional circuits. It's the hippocampus, other areas that affect even things like memory and control of emotion. The fibers that are vulnerable for compression in Chiari are fibers that go all the way up to these central areas, and up to the frontal areas, and up to the areas like the basal ganglia and so forth, and the thalamus. And so we found that in some of our tracking papers, as have others. And there is, through those fiber connections alone, certainly ways that higher cognitive functions can be affected. But the brain is pretty resilient and is pretty what we call robust. So the degree to which they are altered and the degree to which the brain is disrupted by them, I think is not understood or can be quite variable. And of course, I would say that of course people who are pinched back here have fibers which are affected to those areas. How much it really is responsible for symptoms and personality, we just don't know yet. Because again, there's a lot of fibers, and there's a lot of robustness in all the circuitry that might compensate. And we found, for example, with the neuropsychological studies and the tracking studies, that certain areas will compensate and actually be better because certain areas have deficits. So how that really boils down to affecting systems and symptoms is another matter.
Mm-hmm.
I don't know if I've answered your question or not. I don't know the particular study you're looking at, but I know the fiber tracking studies.
Yeah, no, and I think one of the frustratingly running themes of today's talk is just how little we actually know so far. A lot of this work is ongoing, and it's just so early days that we can't really necessarily say much about it.
Although there's been a lot of new thinking, new frontiers that are opening, and the closed-mindedness of just thinking that this does one thing and squeezing and to decompress it is really what's we moved on from. So it's a good era too. Right.
That was very positive. Thank you. Okay, so there's 2 to 3 more questions then. This one's interesting. Has anyone ever done an MRI, an axial MRI or cine MRI in a patient with a suspected tethered cord? And I don't know the answer to that.
A axial or cine in the spinal cord? Because yes. Oh yeah. We used to actually push our radiologists to get cine flow spinal cord motion, and it was uncertain as to exactly, because we didn't know much about the norms. But there was some, and I think there's some published work out there as well, and that when a spinal cord is obviously tethered and tight, it will move less. It will move up and down less, certainly, and it may see differently in the canal, and it would, in a sense, bounce more or less. And also we looked at movement, spinal cord up and down, because if it's loose, it probably will not. There's a certain amount. If it's very tight, it might not move, and if it's very loose, it might not move. With you're looking at how it moves with the heartbeat, basically. And so at certain amounts of tightness, it will actually move more or less. And we used to look for restrictions in motion in the spinal cord due to tethering. So that's been done in the rostrocaudal direction in terms of movement up and down. And we've also looked at it, other people have looked at it in the movement anterior and posterior as well. Basically movements with the heartbeat, yeah.
Okay.
The ultimate value of those is I'm sorry to keep saying things like this,
No.
but it is not known because the norms of what is normal and so forth are not that clear.
This one's interesting, and it gets to what we were just talking about. If you could have any research project done now that you would understand something about this, what would that thing be? I guess open-ended.
I think the understanding the process that actually we talked about going from a congested and compressed area back here to its branching off effects on the rest of the brain, and how it creates the variety of symptoms is such it's something we really need to know much better to understand the symptoms that occur with Chiari, the variety, and what we can improve and what we can't. And is decompression of a certain area, is it reversible? Is it not? Is communication of fluid enough, and so forth. So understanding the relationship between compression and damage here and the rest of the brain is something I think is key for us to understand. Lots of people are trying. We're trying to look at how the brain is deformed with Chiari and how it changes after we've decompressed it. I've sometimes been happy with the decompression, and then the cerebellar tonsils, which were wedge-shaped, blossom out and get bigger. You know,
yeah.
The deformation disappears. Another thing that I think is really interesting is the symptoms that occur. Why is it that, and this is something everybody's looking at, why is it that some anatomy looks just the same and symptoms are occurring now? Is there something like inflammation that is causing this, something far and away different from compression that we're just missing? And again, the other upper functions like emotional control and so forth, I would love to know about those. But all those things, I think we have to start here, because the problem, I mean, as a neurosurgeon, I really think the problem is back here, and it is compression. But we have to be careful about what's causing the compression, if it's fluid dynamics or cranium or whatever. And even though it begins here with compression, to understand how the symptoms evolve and how they affect the rest of the brain, that's the I think most interesting and ultimately clinically important question.
Yeah, I mean, well, the pathophysiology, or how that disease process happens, I mean, that's what you'd have to treat anyway. So it's exactly.
Yeah, we can't treat it well. We can do pretty well, just in most cases decompressing really tight things. It makes sense. But to do it better and to do it more consistently and not to make some people worse, we have to understand the physiology much better.
Yeah, I second that. So you're on. But so there are two questions or two people asked this, but it's the same question. So how can people get in touch with you specifically? So I know if someone were to reach out to Johns Hopkins, how could they know that they would be able to see you? Because everyone loves you so much and they would like to see you.
Well, you just have to, you call Hopkins and you request my office.
Okay.
It's really that simple.
Right.
And I see mostly adults. I am certified in pediatrics. I still do pediatrics. However, the really small kids, infants, I let the pediatric team do that. But I see young. I'm treating 10-year-olds and 12-year-olds as well. But I have a mostly adult and young adult practice, and I'd be happy to see anybody.
Yeah, and then I guess to this, I've been kind of ending all of these with this question, since we're in such weird times with COVID and everything. Are you seeing patients from out of state? Do you do remote second opinions, anything like that?
I have to say, like all of you, I've grown accustomed to these little squares.
Right.
And I think telemedicine is one of the best things to come out of a tragic situation. We do. And right now, with the COVID situation so active, it has been quite liberal. There's a large number of states that we can telemedicine with. I can also telemedicine with anybody that I've started with at follow-ups. But I can do new telemedicine visits with a number of states. There's actually a list of maybe 15 to 20 that is allowed. There's other that's allowed under certain situations. But yes, I do telemedicine visits. I think it's a great way from a person from a distance to get evaluated if it's permitted. The question is, and it really is an open question. I actually asked the dean of our school this 2 weeks ago. When the COVID, in a sense, passes, as it will, what is going to happen to the telemedicine issue? And we are trying very much to maintain a large part of telemedicine ability because it's wonderful. I feel like an old-time doctor. I'm making house calls.
Yeah.
It's kind of neat. I get to see the paintings on their walls, and they get to describe get a lot of information, not physical exam, and that's still important, but we can get a lot of information which says, hey, it would be worthwhile you even coming here or not. And many times it's not, but it's still good information for them.
Yeah, absolutely. So that would be great. So again, if someone wanted to see you either in telemedicine or in person, they're going to call your office and ask for your schedule specifically, or how does it work? I'm sorry, I forgot already.
Just call my office and they can self-refer. They just call my office and ask for an appointment. Yeah.
Okay.
There's also on the internet, I think on the operators list, also the Chiari Center. The Chiari Center has, as I listed right at the beginning of my talk, about 4 neurosurgeons that do a lot of Chiari. We all do a lot of Chiari. And I recommend them all. But if you say Chiari, you say specifically for me, it'll just come to me.
Okay, perfect. Well, thank you, Dr. Luciano. That was awesome.